Precision medicine, or sometimes people say personalised medicine, is something that has actually kind of always been used, but very crudely. In the sorts of infections we work with a lot are with cystic fibrosis patients. So these are patients who have a genetic disorder. They're diagnosed at birth. It's a disease that used to be considered to be a disease of children for the simple reason that nobody ever made it to be an adult. It's such a severe disease. And the thing that mostly causes people to have serious morbidity and then to die, chronic lung infections with bacteria. Now, fortunately, we've improved, and the median life expectancy now for a cystic fibrosis patient being born at the moment will be about 40 years. So we have improved, and one of the ways we've improved is in looking at what bacteria are actually present in these patients and targeting therapy towards it. And so there's always been a little bit of that, because you look at what pathogenic bacteria are causing the infections and you choose antibiotics on the basis of that. But it has been relatively crude, and we are now entering an era where we can do it in a much more sophisticated way, because it's become apparent that it's not just a simple matter of one bacterial species being present. There's actually a complex microbiome, there are interactions between them, and there's also the fact that one species evolves diversity, and the population as a whole is what you need to look at. Whereas previously we were just looking at single isolates, growing them up in the lab, doing some antibiotic tests and saying, use that antibiotic. We've now realised that that's far too crude, and so we can take that forward. But I guess there's always been an element of looking at individual patients. But I think we're going to need to do that in a much more sophisticated way in the future. And the big driver for that actually is antibiotic resistance, which is a general huge problem. And we have been just using antibiotics really a little bit untargeted and with poor evidence often. So we're going to have to be much more clever about how we use antibiotics and when we use them, because if we do manage to develop new antibiotics, we really want to limit their use so that resistance doesn't develop too quickly, because we should be learning the lessons from the past where overuse and inappropriate use of antibiotics has led to this problem with resistance. So in these patients in particular, they have a lot of antibiotics, and the evidence for using particular antibiotics is not great. And so by using more sophisticated methods, we hope that we can inform clinicians so that they can make better decisions, but also limit the uses of antibiotics so that they don't drive resistance, which is not only a problem in these patients, it's a problem for everybody as we come to the next couple of decades, where what were previously routine infections, which were easily treated with antibiotics, we're going to find more and more can't be treated with antibiotics because we've been driving resistance through inappropriate use of antibiotics. Well, this is the beauty of cystic fibrosis. They use lots of different antibiotics in lots of different combinations, but there's no great clear evidence that any one is any better than any other often. And so even in the same cystic fibrosis clinic, they will use different antibiotics with different patients. And so they are kind of guessing, they're in the dark somewhat. They know they have to use something because the patient isn't well and is infected, but the antibiotics as they're used at the moment do not actually clear the infection. So we do need to move beyond that. And we need to try and figure out, actually, it's quite likely that sometimes antibiotics are used and they drive the bacteria to adapt in a bad way, which actually makes them more difficult to treat. But we still don't understand too much about that. The big development is that we now actually have the tools and the technology where we could ask those questions and actually take things further and become a little bit more sophisticated. Well, I'm hoping in the field of infection generally that antibiotics will be more carefully targeted and better targeted on the basis of more sophisticated data, whether that be predictions of antibiotic resistance from using genomics analysis of bacterial isolates, or even better if you can just get samples from the patient, profile the microorganisms that are present using some sophisticated technology and predict which are the best therapies to use, so that with better targeting you can you can make sure that you don't overuse antibiotics and you don't use inappropriate antibiotics. The trick at the moment is that the data, there's an enormous amount of data. The bioinformatics involved is complicated. Converting that into a form that clinicians can understand, that is the main challenge. Well, first of all, figuring out what's important and how you can predict how the bacteria will respond, and then that has to be translated into something that the clinicians can use. So within a decade, I would expect we would be much better at doing that. I think even sooner than that, there are going to be advances in using analysis of the microbiome generally, particularly the gut microbiome. And we've heard several talks, and we'll hear more at this meeting about that. It's clear that the microbiome is implicated in certain diseases. Exactly what to do about it isn't quite so clear yet, but hopefully that will be the near future.